Yeah. So, hello everyone. First of all, good evening to all of you. I am Vikas Singh from medical team of Universal Nutriscience, that is UNS, and it's my pleasure to welcome you all to the fifth edition of the Amogs webinar series on behalf of UNS. At UNS, we take pride in organizing this monthly webinar focusing on critical topics in gynecology. These sessions provide invaluable insights from esteemed KOLs in the field, fostering learning and collaboration within the medical community. Today's topic has been very interesting on the benign breast disorder, which addresses a condition that is increasingly common among the reproductive age women from menarche to menopause. And as a gynecologist, you may often serve as the first point of contact for managing and guiding these patients, making this discussion highly relevant to your practice. To lead the session on today benign breast disorder, we are honored to have Dr. Santanu Sen, a distinguished expert and professor of general surgery at Medical College, Kolkata. Uh, Dr. Santanu Sen has also been the faculty of general surgery in WBMES from last 22 years. So Sir has a very rich experience. You can count on his experience and what talk he will be delivered. It's going to be highly scientific. And he is a senior consultant and a general surgeon at several private hospitals and nursing homes in Kolkata from last 16 years. And he has various awards, as you can see in his uh, curriculum vitae. That is a life member of Indian Medical Association and author of several research articles in index medical journals and an examiners in university and co-chairman of multidisciplinary research unit and MGM Medical College, Jamshedpur. We are eager to hear your insights, sir. Over to you, sir.
Good evening and most welcome everyone on board this webinar, which is organized by UNS on a very burning topic of the benign breast disorders, its clinical examination, especially from the purview of a gynecologist, and the role of EPO, that is evening primrose oil. So I think we will jolly well start off with this presentation itself. So everything is fine.
Yes,
Everyone,
sir.
this PowerPoint presentation is visible to everyone, and I am audible most probably.
Yes, sir, you are audible.
So let me start the presentation. Yeah. So as a gynecologist, what Dr. Vikas has rightly pointed out, please the next one. So they are the primary physician who encounters any female, especially in the reproductive age group, coming with breast problems. So that is the first contact point. In fact, this is the responsibility of the gynecologist also, over and above the examination of the pelvic organs and the reproductive organs, to go in for raise the suspicion and have a look at the breast. The suspicions are raised when you find abnormalities in the overall breast shape, you find changes in the skin color, you find the skin dimpling or POD orange or orange peel appearance, or might be certain retractions and spontaneous nipple discharge. So proceeding ahead, next slide. So now the main concerns. Now, whenever we find a gynecologist encounters this, usually the patient comes down with mastalgia, that is breast pain, a palpable breast lump, and nipple discharge. These three are the main symptomology of breast. So now, whenever the patient is anxious and presents with these symptoms to a gynecologist, the issue for the woman is whether she is suffering from malignancy or cancer, isn't. So she tries to affirm or assure it, get an assurance from the gynecologist. Now, at this juncture, obviously, the gynecologist knows that most of the clinical breast changes in women are benign. In fact, only 3 to 6% are malignant. So, in fact, today we'll be dealing mostly with the benign breast disease, its clinical implications, examinations, assessments, and the role of evening primrose oil in managing that. So to mastalgia. Mastalgia is, next slide, mastalgia. The next slide, please. Yeah, fine. The mastalgia or mastodynia. So mastalgia is the symptom of breast pain. It's one of the commonest symptoms of breast ailments. So this mastalgia may be bilateral or unilateral, and it also can be cyclical and non-cyclical. So, however, if we can get down to the difference between the cyclical and the non-cyclical mastalgia, the implications, you find that the cyclical mastalgia usually starts off 1 to 2 weeks prior to the period. It's a diffuse one, bilateral usually. Radiation may be there to the upper arm and axilla. And it may be that there is a difference between the two breasts. One of the breasts may be having more pain than the other one, and it gets relieved once the period is off. Obviously, the cyclical mastalgia is not much related with breast malignancy. But when we come to non-cyclical mastalgia, there's a difference. It's usually is a unilateral one, particularly localized to particular quadrant of the breast, and it usually resolves up to 50% of the cases without any treatment. Now, if you think about the various causes of non-cyclical mastalgia, these includes this breast cysts, periductal mastitis. Rarely, it may be associated with underlying malignancy, but remember, in those cases, usually that's an advanced malignancy. So the next slide. Now, if you come, as I was telling you, regarding etiology of malignancy, so etiology of mastalgia, you find that in the cyclical mastalgia, it's related to the hormonal imbalances. So it's an increase in estrogen level, decrease in progesterone, and there is, before the periods, a certain increase in prolactin. So this creates a milieu, hormonal milieu, which predisposes for cyclical breast pain or cyclical mastalgia. And while in the non-cyclical mastalgia, you find it is not much related to hormonal variations. Rather, it's most likely to be of musculoskeletal etiology. In fact, the commonest cause of non-cyclical mastalgia in my practice, I found out to be, costochondritis, and that's very difficult to treat. The next one. Now, when the patient comes down with mastalgia to you, so what is the flow chart of that? So we go in for a history, physical examination, that is a clinical examination. Now, if you don't find a lump, then the issue is if it's a cyclical pain, cyclical mastalgia, imaging may not be desirable. You may skip it. But if it is a non-cyclical pain, then surely you go in for imaging. Now, if you remember the triple assessment for the any breast disease, the first one is the history taking and the physical or clinical examination. The second assessment is imaging. Now, you have two options of imaging. One is the high resolution ultrasound of the breast tissue, in fact, and both the axilla, and another is mammogram. Now, nowadays, it has been very clearly shown that, in fact, high resolution USG is one of the cheapest and widely available investigation used as a screening and also as a diagnostic modality of breast imaging, irrespective of age. While there was certain encouragement or enthusiasm regarding digital mammogram, but nowadays mammography is going for disrepute even as a screening tool, and this has been showed in evidence-based studies. So nowadays, in fact, you cannot go in for mammography. It is of no use of advising mammography below the age of 35. In fact, this age modality in some countries, the age criteria is 40. So if you go in for if you are going in for an imaging modality, remember that if it's age below 35, at least we practice over here, it's only high resolution USG of both breast and axilla. One issue is very important, that please request the radiologist or the whoever is the imaging is doing, please request him or her to comment about the BIRAD. Even if it is more than 35 years age, it is high resolution ultrasound and USG. This workflow shows the mammogram only, but remember it should be dual imaging, that is both high resolution USG and mammogram, but after the age of 35. In the cases of non cyclical pain, focal, diffuse, in both the cases, and even with cyclical pain, it is desirable at least if the age is more than 35. Now, if it is a palpable mass, so you go in again for that same age criteria and go in for the imaging. Next slide. So talking about cyclical mastalgia, the treatment, you have, as I told you, because there are certain hormonal influences which predispose for the cyclical mastalgia. That is, if you remember, we are speaking about increased estrogen level, decreased progesterone, and intermittent increase of this prolactin just before the periods. Anyway, even in the conservative management of cyclical mastalgia, we first reassure the patient that there's no fear or apprehension of this disease to be a breast cancer or this disease as a predisposing factor for breast cancer. Next, we usually advise to go in for lifestyle changes based upon epidemiological evidences of cyclical mastalgia. So these are basically harping on a low fat diet with active lifestyle and also using well fitted breast support, that is brasier. And obviously, you can go in for NSAID, but that should be absolutely dependent or a subjective matter depending on the patient's severity score. Otherwise, the drugs that can be used in cyclical mastalgia, if it is severe, are ranging from tamoxifen, danazol, bromocriptine, goserelin. Now, usually the danazol is the commonest drug that is usually used in our practice. Tamoxifen is also being used for the last about 10 to 15 years. And bromocriptine is reserved for only if you find that there is an evidence of increased prolactin. In severe refractory cases, you can use goserelin, but remember, the most important issue of the constraint of these drugs are the side effects. So treatment options available for management of mastalgia often come with the cost of significant side effects. Anyway, now coming to the palpable breast lump or mass. Now we are talking about mastalgia. We now come to the palpable breast lump. Now, the next slide. Yeah, thank you. Now, breast cancer. Now, whenever a patient has a breast lump, he or she is very much anxious getting down to the gynecologist at the first go. So, sir or madam, please look whether I am suffering from any breast cancer or not. I'm having a breast lump. So reassure her that breast cancer is diagnosed in only a very minor percent of new breast lumps. So essentially, you have an approach of investigating the breast lump. That is, the main objective of investigation, or rather screening, is limiting the over investigation, being over enthusiastic. Even I found in very rare but hilarious cases of going in for MRI breast. I don't know what is the use of that, even at the first go. And also preventing the misdiagnosis of malignant breast lesion. So it's a balance between the two. That is, you don't go in for over investigation. At the same time, you don't misdiagnose or rather miss out on the diagnosis of a malignant breast lesion. So it is optimization. The next slide. Now, clinically, as I told you, I have already commented about this triple assessment. So I touched on the first mode of assessment, that is history taking and clinical examination. The second was the imaging, which consisted of HRUSG, the high resolution ultrasound, and mammography. The choice being dependent upon the age, 35 or maybe 40. And the third one assessment is basically a biopsy, that is histopathological study. Cytology is not desirable, but obviously, if you don't have the availability of a true cut biopsy, then surely you need to go in for cytology. Now, remember that breast cancer increases with age. In fact, age is the most important risk factor for breast cancer. So, if you go in for the next slide, age based evaluation of breast lumps, you will find that usually during the first 2 decades, we hardly think about that we suspect that there is a breast cancer. During the early reproductive age group, we are not concerned much. The risk obviously increases when the patient enters into her fourth and fifth decade, usually during the perimenopausal age group. The next slide. Now, as I was telling, the first modality of this triple assessment is history taking for breast lumps. Now, while you are taking the history, it's very important to mention the age, as this is the most important risk factor for breast cancer, an independent risk factor. Now, while taking the history of the breast lumps, you take about the onset. Usually, it is insidious onset, the duration being not maximum for about months, maybe a year or so. And the progression, you will find that it is progressing. Obviously, you need to take the past history of any previous breast operation or biopsy, and also remember to take the past history of any radiation exposure. Usually, remember this radiation exposure should be at least more than 10 years before. In the family history, it's very important to exclude the family history of breast and or ovarian carcinoma in first degree, that is mother and siblings, usually sisters. In second degree, that is grandmother, both paternal and paternal and maternal aunts. In fact, let me share that in this family history, it is not only that you ask the patient about the female family members, first degree and second degree, it's also important to ask the family history of prostate cancer in male family members. Basically, if you go in for the genetic etiology, you will find that these are related to BRCA1 and BRCA2 genes. Now, in the personal history, the patient should be having a history of whether she had a single pregnancy or whether she is nulliparous or multiple pregnancies. Then history of lactation should be taken, and it is not the OVP what the slide shows. It should be OCP, oral contraceptive pill intake. And also, lastly, hormonal replacement therapy in postmenopausal patients or patients who have undergone hysterectomy. So these are very important because all these are related risk factors for breast cancer. In the menstrual history, we should mention about the age at menarche and age at menopause. In fact, the risk factor in the menstrual history is early age of menarche and late age of menopause. Next slide. So in the physical examination, we had already shown that during inspection, you try to witness whether there's any asymmetry, whether there is any color changes of the skin, other appearance changes of the skin, there is purity orange in a retraction. Now, while palpating, you try to detect the lump and note the difference on palpation of the benign lesion, which are usually regular, round, having regular borders, while the cancerous nodules or the lumps will have irregular shape. The consistency, it's very important to note that the malignant lesions are usually firm to hard, while the benign ones are firm, at the most rubbery, but not hard. Another important palpatory finding to differentiate clinically between a benign and a malignant lesion is fixity of that breast lump which you have palpated. The three issues of fixity are related to the breast tissue itself, to the skin, and to the chest wall or pectoralis major muscle. In fact, while clinically checking of the fixity of that particular breast lump, you will not only be able to differentiate between a benign and a malignant breast lump, but at the same time, clinically evaluate the T stage, that is the tumor stage of the malignant breast lump. Skin changes, that is ulceration, and orange pill appearance, that is purely orange appearance, also needs to be mentioned. The next one, we will be talking about the management of breast mass. Now, if you have a breast mass, again, what you do is that you go in for a clinical examination, imaging, and a true cut biopsy. Though the slide shows FNA as an alternative, but surely the FNA will stand as a very distant alternative. Surely nowadays, biopsy and biopsy is recommended in the triple assessment of any breast mass or even with mastalgia. Now, if it is a woman below 35 years, which is compatible, you get a true cut biopsy report which is compatible with fibroadenoma, then you can go in for follow up. I'll be talking about a bit about fibroadenoma later on. But if it is not compatible with fibroadenoma, in fact, if there is a atypia or some dysplastic changes, then surely you need to go in for at least an excisional biopsy and have it confirmed to exclude any malignancy. While if it's more than 35 years, in fact, that also stays on. So remember that age is not an important factor while detecting breast mass because the final assessment will depend upon the true cut biopsy. Now, these are the different studies that have shown the incidence of the fibroadenoma and the fibrocystic disease. As I told you in today's presentations, usually the breast symptoms, whatever the patient comes down to gynecologist, the commonest etiology is, now get down to the next slide, please, Dr. Vikas. So as it shows, it is the two most common benign tumor conditions, that is fibroadenoma and fibrocystic disease. The studies shows that very. The other points are also to be noted that the other benign breast diseases includes gynecomastia, benign phylloids. In fact, you have the inflammatory lesions of abscess, granulomatous mastitis, but these are not that common as benign as the fibroadenoma, the fibrocystic disease. So, in fact, today we will restrict our discussion, next slide, please, to these two, that is fibroadenoma and fibroadenosis. So, what is fibroadenoma? It's basically a non tender mobile, some clinically denote it as breast mouse because it is not even fixed to the breast tissue. So, while palpating, you will find that the swelling is the lump is moving about within the breast tissue from one quadrant to another. It's a round one and a firm lump. So all these clinical parameters are conforming to benign lumps, benign breast lumps. In fact, these are the most common lumps across all age groups. So, in fact, in adolescent, in young, as I was telling you, during the first, second decade or the third decade, usually the 95% of these breast lumps are benign and they are fibroadenomas. So now coming to the next slide. So if you get a fibroadenoma, what do you do? So if you get back to that slide, you will just refresh your memory that we don't do anything. We basically go in for a careful observation, follow up. Yes, we need to assure the patient that this is not a malignant tumor and this fibroadenoma is a benign one and this is not going to increase or convert itself to breast malignancy. So that is very important. Well, surgical excision, surely surgical excision is indicated if the mass is symptomatic or the patient desires so, or it is rapidly growing and the cytology shows atypia. In fact, remember, so I was mentioning that while describing the flow chart of the management of breast mass. And sometimes some indications, some say the indication should be size more than 5 centimeter, go for excision. The next one, so another common benign breast disorder, as I showed it, is a fibrocystic breast disease. Now, this is not a discrete lump, rather, it's a lumpiness of breast tissue. So, it's fibrosis and fluid filled spaces or cysts. This is also quite common. In fact, during 90% of their life, 90% of women present with this or suffer from this fibrocystic disease at some point of time. And remember, fortunately, this is also not associated with increased risk for malignancy. The next one. Now, this is a new term, the abbreviation of ANDI. Nowadays, fibroadenoma and fibrocystic disease, the two common benign breast disorders, has been amalgamated within the same clinicopathological syndrome of aberrations of normal development and involution of breast, which is shortly called ANDI. Now, in the clinical spectrum, you have a spectrum which is ranging from discrete breast lump, that is fibroadenoma, to mastalgia. And on the another hand, in between, you have the admixture of these two symptoms. That is, it may be lumpiness with or without breast pain, mastalgia, usually cyclical. Similarly, the pathological finding also, there are four pathological findings which usually range from adenosis, you may find them, fibrosis. In fact, in fibroadenosis, you find fibrosis in the histopathological examination, papillomatosis, and also cyst formation. So now coming to the third breast symptom, we talked about the mastalgia, breast pain. We talked about the breast swellings, fibroadenoma, fibrocystic disease. Now we come to the third important breast symptomology, that is nipple discharge. Now, nipple discharge, remember, whenever a patient comes down, try to differentiate whether it is unilateral or bilateral, single duct or multiple duct. What is the color of the nipple discharge? You have a milk discharge or a whitish one, a bloody discharge or a greenish one, and whether it is associated with lump or pain. Now, the nipple discharge, the etiology is if it's a greenish one, or if it's a bloody one, it's a duct papilloma, which is a benign one again. And if it is a greenish one, usually it is duct ectasia. But remember, ductal carcinoma, especially in the central region and especially in the advanced stage, may present with reddish nipple discharge. In fact, 80% of women have an episode of nipple discharge during the productive years. But remember, even postmenopausal women may come down with a nipple discharge. The evaluation of nipple discharge, again, this is the same. We go in for a physical history taking and a physical examination, go in for an imaging, and you need to clinically differentiate whether it is, what is the color of the discharge, whether it is coming out single or multiple duct, as I have described. Now, if it is a physiologic one, if you find that lactating breast or it is within the reproductive age group, milk is coming out, obviously you go in for assessment of the systemic causes of TSH, elevated TSH or prolactin level. That would basically be managed by medical management. And in the other part, for the breast assessment imaging, again, you harp on that age criteria of 35 years. If it's below 35, you go in for HRUSG of breast. And if it's more than 35, you have a dual imaging. If it's a pathologic, say it's bloody discharge or greenish one or even milky one in the postmenopausal age group, then obviously you need to go in for imaging according to the depending on the age. The next one. So coming to the management of nipple discharge, physiologic, obviously we have commented about that you need to go in for observation and go in for medical management after hormonal assays. While the pathologic one, after imaging assessment, if you find that, and also going in for if the lump is present, or if you can go in for any duct, whatever discharge is there, you can go in for a cytological examination. If you find that there is low risk of cancer, then you can go in for follow up, or if required, if it's a refractory case, you need to go in for major or minor subareolar duct excision. Usually, that is known as macro or micro dockectomy. But nowadays, those surgeries are quite reserved only in refractory cases. Now, if it is high risk, then surely we need to go in for different modalities considering the DCIS and LCIS, that is ductal carcinoma in situ and lobular carcinoma in situ, proper assessment. The next slide. Now, coming to the role of evening primrose oil, that is EPO, in management of mastalgia and benign breast lumps. If you remember, the cyclical mastalgias, you have the different hormonal preparations starting off from tamoxifen, danazol, bromocriptine, but these are always have their restraining factors of side effects. Now, we have a product that is evening primrose oil, which is bereft of these side effects. What is it? It's basically an extract from a plant. It's rich in omega fatty acid, and it itself is a rich source of linoleic and gamma linolic acid. These are basically essential fatty acids. Now, women with breast pain, it has been found that usually have a low concentration of GLA and its metabolite. Basically, it is related with certain disturbances in lipid metabolism. And it has been shown that the evening primrose oil, individually or along with vitamin E, we will come to it later on, does influence this lipid metabolic abnormalities so that the different, or rather the clinical symptoms of ANDI, that is mastitis or breast lumps or lumpiness, will be relieved. Now, coming to the next, that is the role of, no, please, Dr. Vikas, I haven't gone in, yeah. Role of evening mastalgia and breast lump. So it's basically, as I was talking about, if you come to the molecular level, it's restored the etiologies, I mean, the ways of actions are, it restores saturated with unsaturated fatty acid balance. As I told you, that basically, hypothetically, the benign breast disorders, they have harbor some kind of lipid metabolic abnormality. So basically, it influences that or modulates that. And it has been found that it increases the prostaglandin 1 level, but decreases the conversion of arachidonic acid to pro-inflammatory leukotrienes. So it somewhat acts like the NSAIDs in this way. So in fact, the textbooks also refurbishes that knowledge that EPO diverts harmful prostaglandins and replenishes with a similar one, that is the prostaglandin 2 to prostaglandin 1. And it also suppresses irritability and depression, mainly related to some CNS effect. And it has also been proved that EPO is efficient and has a good safety profile. So it is used as a first line option for the management of mastalgia, and that too in the reproductive age group, where it is quite common occurrence. The next slide. Now, as I was telling you, that evening primrose oil by itself has the effect, but this effect is accentuated by combination with vitamin E. So it has been clearly shown that this has a superior efficacy compared to individual treatment. Now, if you come to the next slide, you have the next slide, please. Yeah. So you have around 4 studies. So basically, different drugs have been, combinations have been attempted, and it was a comparative study. It clearly shows that the combination of evening primrose oil plus vitamin E has a 90.63%, the highest percentage of patients being benefited. So surely it stands over NSAID or evening primrose oil alone. Now, There are clinical factors which affect the efficacy, therapeutic efficacy of this evening primrose oil and mastalgia. Now, again, you have a retrospective case control study way back in study where about 1015 patients were included, and it was found that there was significant reduction in visual assessed score, pain score, that is VAS score, after 6 weeks. So at least you should continue the EPO for 6 weeks. So that is very important. And the side effects were really insignificant. There are other studies related to the fibroadenoma and the cysts, and this also confirms the efficacy of EPO. In fibroadenoma, there was reduction of size in about 52% of patients within 6 months. And in the cyst, the recurrent cyst formation, that was also lower. So it is not that the EPO has a role in only mastalgia, that is breast pain, usually cyclical mastalgia, but clinical trials have shown its efficacy also in fibroadenoma and USG finding of breast cysts. So now coming down to the take-home points. So today's presentation hints about the importance of history taking along with the physical or the clinical examination, imaging of the breast, both HRUSG of the breast and mammography, depending on the age. 35 years, we took it for our criteria, but maybe 40 also. And histopathology, if it's not feasible or possible, go in for cytology. So with these three modalities of triple assessment, we can differentiate between benign and malignant disease. In fact, the burden of the breast disease, especially in the reproductive age group, these age group patients usually present to the gynecologist as their first attending doctor. And the commonest breast disease in this age group is benign, fortunately, not a malignant one. So, gynecologists are the first responding doctors. And given the incidence of mortality rate of breast cancer, breast screening is also important within this age group of patients. And lastly, evening primrose oil has surely proved that it's an effective and efficacious way of managing mastalgia, which is safe, and it helps also to reduce lump size in fibroadenoma near about 50% cases and fibrocystic disease. So, with this, I thank everybody for their patient hearing, and also thanks to the UNS team, especially Dr. Vikas, for your logistic support. Over to you, Dr. Vikas.
So thank you, sir, for your wonderful talk. I think just we can wait for a few seconds. Aman, can you confirm that any query from the audience on the chat box?
Okay, sir.
Yeah, just confirm within a minute.
Yeah, surely.
No, sir.
Okay. So, like you have been saying about the diagnosis and whole of the things you have explained in very detail, but
Mhm.
I just want to know, have you tried evening primrose oil apart from benign breast disorder somewhere else or in some other diseases just you want to share or no?
No, I don't think that evening primrose oil is as such approved for use in any other areas.
Yes, yes.
But surely, myself, if you have gone through my CV, you will find that I am already a co chairman at the multidisciplinary research unit.
Yes.
Basically, these are the units which are sponsored by ICMR. And
Okay.
I am the external resource person chosen by the ICMR
That's
to be
great.
stationed at this MGM Medical College, which is a government medical college at Jharkhand,
Okay.
at Jamshedpur in Jharkhand.
Yes, yes, I said.
So, being a researcher by myself, it's very important that we can start off with the trial, but surely, hypothetically, you can use evening primrose oil in diabetic issues, complications, especially neuropathy, some cases of vasculopathy, especially in neuropathy, along with vitamin E.
That's great, sir. Yeah.
because vitamin E has empirically been advised, especially in refractory neuralgic pain, where other diagnosis is not feasible or possible. So vitamin E is quite regularly empirically being prescribed.
In
So
refractory neuralgia cases, you said, no?
yeah. So obviously, the studies needs to be done to comment about. In fact, some samples pilot study maybe after before which we can proceed for application for trials and all these things. In
Okay.
vitro studies are important, trying to check out with
Yeah.
at the cellular level what is
Yes.
the role of this EPO might be within the cell culture of neural tissue and all these things. So
Okay.
after that, if you have certain hypothetical, data
Data.
which can have act as an evidence regarding this, then you can put forward your finding
Yes.
for going for some trials or something like that.
Yes. Would you
That
like
is one of the areas, surely, that may be.
would you like to share your experience on something like where you have used evening primrose oil in this benign breast disorders, one or two cases, and what's the
Yeah,
result
surely.
you have found?
Surely, it's not about one or two cases.
Yes.
In fact, whoever representative meets us from UNS, he or she knows it, that we go in for prescription of evening primrose oil in the reproductive age group. In fact, in my opinion, or in my practice, what happens is that in the patients within the reproductive age group, if I find a patient comes down with cyclical mastalgia, then I think even after assurance, if the pain is refractory, or if in the VAS score, I find it's about to the level of 3 or more, then surely I would go in for evening primrose oil, knowing fully well that at least I'm doing no harm to the patient. That is, I'm not creating a hormonal influence or rather imbalance again by the drug itself.
Definitely,
So,
sir.
especially of patients who doesn't have their family complete. So, even in these patients also, evening primrose oil is much safer than the other hormonal alternatives we think of. In the post-menopausal patients, surely that issue, the side effect issue of the hormonal drugs or the hormonal agents don't come much into consideration. But even still, in those patients, I think EPO may surely be attempted as a first line management. But
Definitely.
in the reproductive age group, I would surely suggest that EPO may be the drug of choice.
And in fibroadenoma cases, sir, is the lump
Yeah,
size is
you have commented that one of your studies might be a reference has been given,
yes, yes.
but in fibroadenoma cases, again, we basically confirm by histopathology that it's a fibroadenoma size is less than 5 centimeter. All other indications of excision for fibroadenoma is not there. Then surely we go in for conservative management, assurance, breast support, regular follow up, and these things. But in these cases also, if I find that there is an evidence of reduction of fibroadenoma in more than 50% of cases by using EPO, but the duration is quite long, about 6 months,
Yes, it's a long
then
duration, at least
yeah,
3 months.
then taking the patient consent, we can empirically advise that.
Okay.
Even in your study, you have shown that breast cysts they also respond specific, especially the recurrent cyst formation chances get lower by the use of this EPO. So these are surely the arenas which may have certain use of EPO.
So what I have learned from the last 1 year after meeting much of the gynecological surgeons and breast surgeons that they use EPO for the long term for 3 to 4 months at least in these cases if the lump size is small. If the big is they go for excision and all these things. But if it's small, then basically they tried this EPO as a conservative management therapy along with reassurance and all these things so that at least whatever the lump size is 2 centimeter or 1 centimeter, it also gets dissolved if it's possible.
Yeah,
So, yeah, that
surely, that's the way. In
yeah.
fact, your study also shows that.
Yes,
So
sir.
I think rightly you have summarized the whole issue.
Definitely, sir. So I would like to thank you, Amogs team, who have allowed us to conduct this webinar, that is Maharashtra Association of Obs and Gynec Society. And lastly, sir, a big thank you to you for your insightful presentation on benign breast disorder. And you have rightly qu- quantify all the things in this presentation, like how to diagnose it, how to manage it, what is the age criteria, and all the things have been rightly said in the presentation and widely covered. Your expertise and thorough explanation have greatly enhanced my knowledge, and of course, I have think so. The audience knowledge has also been enhanced, and this is one of the crucial topics which gynecologists always face routinely in the nowadays in the clinic. And lastly, we also appreciate your time and efforts in sharing your knowledge with us today, the most important thing. And a big thank you to all the participants as well as who have been the part of this session. We hope you have found this discussion valuable, and we look forward to continue and conducting such webinars on a monthly basis. And this has been learning journey together in future webinars. On behalf of Universal NutriScience, we extend our sincere gratitude to everyone involved in this webinar. Have a great day ahead. Thank you, everyone. Thank you, sir. Thank you, sir, for your talk.
Thanks to everyone from my end also.
Recording can be
So,
stopped. Yeah.
yeah. So till we meet again.
Yes, sir.
So till we meet again. So may
Mostly
I
I
sign
will
off?
be coming
Yeah.
to Kolkata on January.
Yeah, yeah.
I'll try to meet you, sir.
Sure, it will be really pleasant, pleasure meeting you.
Yes, sir.
And in the meantime, if you have any presentations or scopes, you can surely leave a note.
Yes, sir. Sure, sir.
Anyway,
Sir, also live can be stopped.
Yes, yes, you can stop.
thank you, everyone,
Okay, sir. Thank you, sir.
especially the
Bye.
UNS team from my end.
Thank you. Thank you so much,
So
sir.
see you soon. Yeah, yeah.
Bye.
Thank you, sir.
Thank you. Bye bye.